Efficacy, SLT is going to give you, depending on when you use it, whether it's first line, second line, third line, how many medications they're on, what their pressure is. But generally speaking, you're going to get an IOP reduction first line, usually between 20 and 35% for SLT. The Glorious trial with DSLT showed an 18 to 27% pressure reduction. So fairly comparable, 20 to 30%, 20 to 35% versus 18 to 27%. So efficacy fairly close, at least according to the clinical trials. Uh, Treatment time, SLT is going to take you somewhere between a minute and a half per eye on the short end, up to 3 or 4 minutes, depending on how many degrees you're doing, how many SLTs you've done in the past, your experience level. So somewhere probably between, a minute and 4 minutes for an SLT versus DSLT is 2.5 seconds, 2.4 seconds to be precise. So much quicker. Most patients with SLT feel nothing during the procedure. DSLT, they do tend to feel it a little bit more during that 2.4 second treatment. You got to go a little bit higher energy with DSLT because it's going transscleral or through the sclera. So they may feel it a little bit more than a regular SLT during the 2.5 seconds of treatment. The upside is it's 2.5 seconds of treatment versus 2 or 3 minutes of an SLT. So that's a little bit about efficacy, how long it takes, things like that.
This terminology of interventional glaucoma has been kind of thrown around for the last couple of years. And for me, it's really not about any one procedure or rushing to surgery. It's really about this understanding that patient compliance is real, and we have to be aggressive early on to prevent further progression for our patients. So how do we do that? How do we balance aggressive earlier IOP reduction, but yet at the same time maintaining high quality of life? And that is the heart and soul of interventional glaucoma, meaning when we start with our first treatments, it really starts with primary SLT. It's the most physiologic way of approaching glaucoma, directly accessing and treating the trabecular meshwork, which is a significant source of resistance for many of our patients. But that then sets it up for this idea that there's a procedure that's a baseline procedure. And it's how we talk to patients about these procedures, knowing that not any one surgery in glaucoma is going to last them forever. So you do your SLT, it lasts a couple, maybe a year, 2 years, you do it again. Less than a year or two, doesn't do enough, let's say, we can talk about drug delivery to a patient. If a drug delivery doesn't do enough, or let's say they need cataract surgery, we do a cataract with our MIGS procedures, and maybe do a drug delivery afterwards. If that MIGS procedure of the conventional pathway doesn't do enough, or let's say it wanes off, they're back on medications, we have other MIGS procedures like the kind of supraciliary space we can utilize. Then we have subcon surgeries. So I think the heart and soul for me, what I've learned over time, is it's a journey. And it's not about any one procedure having to be successful and having to last forever. It's about, hey, now that we have from early to moderate, we have many different options for this patient. It's about expectation building and telling a patient, my job, Mrs. Smith, is to never let you get worse in terms of your vision, but also maintain the highest quality of life. I'm gonna try this beam of light that stimulates your drain, that helps you rejuvenate that drain, called SLT. If that doesn't get us where we want you to be, we have topical drops if we need to, but we have ways to deliver that medications so you don't have to take that every day as well. And if that doesn't do enough, we can go in and open up your natural drain with multiple different procedures. So you set that patient up for this understanding that along that journey for that patient, they may require multiple different procedures. That puts less stress on us as providers to have one surgery that works or we're in trouble. I think that mindset of, hey, let's try this next if we need to, is really been, for me, the heart and soul of interventional glaucoma.
We know that glaucoma in its primary form, which is, primary open-angle glaucoma, is often associated with pretty good prognosis with timely diagnosis and treatment. However, there's kind of this subset of POAG patients, maybe around 15 to 20%, that tend to change much, much faster than we anticipate, even with treatment, and we term these patients fast progressors. And so, more frequent testing, field and OCT data can help kind of identify these patients, but we're just not getting enough sort of field tests. There was a study published in Ophthalmology Glaucoma just last year in 2025 by Stagg et al. That looked at kind of a nationwide claims database, and they found that visual field testing was done about once every 1.6 years, which is kind of far less than the preferred practice patterns of ophthalmology. These results really suggest that visual field testing should be done more frequently, and there's some good concepts behind cluster testing or front-loading visual field tests so we get more of that data in a shorter amount of time.